Okay, so the next thing we're going to do is joint play assessment, and we're going to do both the tibiofemoral joint and the patellofemoral joint. They are both done in the loose pack position of the tibiofemoral joint, which is 25 degrees of knee flexion. So a half foam roller or something like this works really well. This is firm, better than a towel, so when I push down and stabilize, I'm not going to lose my flexion. As you can see, I have the foam roller, Billy, I'm going to scoot it up just a little bit. I have the foam roller up a little bit more proximal, not right at the joint line, because when I do my posterior and anterior glide of the tibia, I want to make sure that there's space for the tibia to move and that the foam roller isn't actually blocking it. So we'll do a posterior glide and an anterior glide. I'm going to move the tibia, which is concave, on the femur, which is convex. So a posterior glide will help with knee flexion. So I'm going to find my joint line. I'm going to come just distal to it. I'm going to stabilize his femur on the foam roller, and I'm going to deliver a posterior glide of the tibia, but I need to stay in the plane. So I'm not pushing straight down into the table, rather I'm pushing at a little bit of an angle. So there's joint line. I'm right on the tibia, and I'm delivering a posterior glide, which will aid in flexion. Now, to assess extension, I can keep my stabilizing hand where it is. I'm just going to reach around and grab the tibia, and I'm going to pull it anteriorly. And again, I have to stay in the plane. I'm not going to pull straight towards the ceiling, but a little bit at an angle. So I can find tib tube. I wrap my hand around, and again, you don't want to have your outside hand doing this because you're going to be grabbing more fibula. You want to grab the tibia. So I'm here, and I'm doing an anterior glide of the tibia on the femur, which will help with extension. Now, the other thing that happens at the tibiofemoral joint is a little bit of medial lateral glide, and this has to do with the screw home mechanism. So often what we do for this one is I find the joint line, and I literally come and I do almost like a shear. So this would be a lateral glide of the tibia on the femur, and I'm going through the fibula, and this would be a medial glide of the tibia on the femur. And those are nice to do, especially if your patient is having difficulty with the screw home mechanism. Okay, so now we're going to leave the tibiofemoral joint and we're going to go to the patellofemoral joint. And the reason you want to do your joint play assessment at about 25 degrees of knee flexion is because when your knee is fully extended like this, the femur is not, or excuse me, the patella is not engaged in the femoral trochlea, and so it has lots and lots of mobility. So we actually want to see what the patella is doing once it starts to engage in the trochlea of the femur. So we're going to keep building this 25 degrees of knee flexion, and we're going to do 4 assessments here. We're going to do a medial glide, we're going to do a lateral glide, we're going to do a superior glide, and we're going to do an inferior glide. Okay, if your patient has had an episode of patellar instability, they will be apprehensive or afraid of the lateral glide. So it's something you're going to want to be aware of with their history. So to perform these, you need to find the medial and lateral borders of the patella. And what I usually do is I just grab with my index finger and my thumb, and I'm just going to move the patella medially and laterally. So this is a medial glide. Not much. Billy doesn't have a lot, but certainly reasonable. Do you have any episodes of patellar instability? Okay. So here's a lateral glide. So I'm just pushing the patella laterally. Any pain with either of those? Great. Okay. And I would have compared to his uninvolved side to see if they're similar. Now, for superior and inferior glide, these things go with knee flexion and extension. So I need a superior glide when my knee extends. So people who are sometimes having difficulty obtaining knee extension, it may be because their patella is not sliding superiorly, particularly in patients who have had some sort of surgery in this area. If you think about people who have had an ACL reconstruction, specifically if they've used a patellar tendon graft, this area may scar down, making it difficult for the patella to slide superior. That's why doing these mobilizations becomes very important. So what I'm going to do for this is I'm going to use the web space between my thumb and digit 2, and I'm going to cup the inferior pole of the patella. If you're having a hard time finding it, you can actually take your other hand, push on the superior aspect of the patella, and you can see how that inferior pole pops right up, and I can cup it. And then I'm going to come down like this because I want my line of force to go superiorly, and I'm going to push the patella superiorly. Okay, that's the whole thing. But you don't just want to be grabbing skin, so you got to make sure you get on that inferior pole of the patella. Likewise, if my patient's having difficulty with flexion, it could be because their patella is not sliding inferiorly. And so to do an inferior joint play assessment or an inferior glide, I'm going to use my web space, come over the superior aspect of the patella, bring my forearm nice and parallel, and I'm going to push inferiorly. Ideally, normal mobility for the patella sliding medially and laterally is it should be able to move about half the width of the patella. I take that with a grain of salt. Men definitely are not as mobile as women. I've had women who have had more mobility than that, but it's comparable to their uninvolved side. Billy has, I would say, less mobility than that, but really very, very similar to his uninvolved side. So I'd say that's probably pretty normal for him. So you always need to compare to the uninvolved side.